Hey guys, welcome back to part 4 of our anatomy focused laser series. So we have gone through the anatomy of the brain. We have gone through common conditions that affect the brain. Let's start looking at how we would treat. And first of all, before we kind of do an overall kind of tips for the brain, which we'll do in part 5, let's look at 2 particular conditions that seem to be the most popular in from an animal perspective that I could find research around, and those 2 conditions are canine cognitive dysfunction and traumatic brain injury. So like I say, there's many other conditions. Research is still very much evolving in this area. We expect that to continue. I know there's some stuff going on at the moment which will be exciting when that comes through. So let's look at canine cognitive dysfunction first. Now, we've talked a little bit about this already. Now let's go back to our anatomy. Primary area that's affected is that cerebrum, so put that up there, or that cerebral cortex. The secondary involvement is that limbic system, the hippocampus, and again we talked about that and the impact of all the signs that we see in canine cognitive dysfunction and where in the brain is affected. So as a result of this, we see memory and learning impairment, we see disorientation, altered awareness, and we get those behavioural and emotional changes, which I've talked a lot about in Diesel's diary video, so go check those out on our YouTube channel. Underlying changes, the beta amyloid plaque accumulation that we get, neuronal loss and cortical atrophy. So that's kind of what's happening when it comes to canine cognitive dysfunction. So how do we apply laser? And again, I've talked a little bit about this, but let's deep dive it a little bit. So first of all, we need to look at the device parameters that we're going to use. And one thing that you'll see with brain research at the moment is we are still learning a lot. So there are some mixed reviews on kind of what parameters shouldn't be used. I think ultimately we have to be guided by what research is out there, what parameters did they use to get the positive results, and go from there. So there was a review done by an Engel, Hamblin and Dunk. So that's an Engel SL 2020, and it suggests from the research available the following parameters that we're going to talk about. So originally, dose rates were discussed 5 to 10 joules per centimetre square, and that was at the level of the cortex that was used. But what we've seen is studies looking at exponential energy decreases during application. So that's as light passes through, the deeper it goes, the less light we get, because obviously the surface is going to, we're going to saturate that surface, and as that light passes through, we get less and less go through. So as that research has been looked at, in human studies, we're actually now seeing dose rates of the brain 20 to 60 joules per centimetre square. And if we relate that then to dogs, I think, if we use it, if we're treating smaller patients, then those lower dose rates are generally fine. When we start looking at our much bigger patients, that's when that 20 to 60 joules per centimetre square probably is a bit more efficacious for them, especially since we've got a bigger area to cover as well. In terms of frequency, so again, historically, you've heard me talk a lot about continuous wave and pulsing, and how when we're trying to reach deep structures, continuous wave very much seems to be the overriding way of getting there, both from a dose and a radiance perspective. More so in the brain research, we've seen pulsing has been used because it works slightly differently to help neural oscillations measured by and do you know what? I think they throw these big words in just to test me. Electroencephalography recordings linked to different mental processes. But that's not to say continuous wave isn't as effective or could be as effective, and actually we're now starting to see continuous wave used. So although pulsing affects differently to continuous wave, actually we're seeing that potentially it doesn't massively matter, but the research is still ongoing, and further research is required to really dive into, okay, why does pulsing do something a bit differently to continuous wave, or actually do they work the same, have the same effects, because ultimately we are now seeing continuous wave used successfully when treating the brain. So jury's out there a little bit on the kind of exactly, like I say, the parameters we should be using, but that is a bit of a guide. And like I say, depending on what condition you're treating, what I would do is look at the research, what parameters have been recommended out there, and then follow that guidance. And particularly, I always kind of say, you know, whatever device you're using, you need to talk to your manufacturers about the most effective parameters that you can use with your device, because they are all so vastly different. As I've commonly said, you could stick 5 machines in front of you. Yes, they all have the label laser or class 4 laser, but they all have very different parameters. So that's really important to note. So how do we then apply that laser? And I'm going to pop a little mini video up here as well of me kind of treating over Diesel, again, as you know, with his cognitive dysfunction. So key points, holding the probe in contact is really important, because if we have space, then we lose some of that light energy. And again, we want as much of that light to reach depth as possible. So having that full contact is going to be the most efficacious way of delivering that light. And for cognitive dysfunction, we want to treat that telencephalus and diencephalus. So we want to treat the dorsal surfaces of the skull and treat both left and right hemispheres. Remember, like I say, the telencephalon is where focus should be, and then the diencephalon here as well. So that's where our anatomy comes back in. If you're using point-to-point, irradiance of 0.25 and 1.5 watts per centimetre square at the skin surface is recommended. Challenge I always find when, and you know I talk about this a lot, whenever I'm doing point-to-point, it's difficult to cover the whole area that I'm looking to treat. So I do prefer scanning when it comes to treating larger areas. If you're doing trigger point work, fasciolation work, you know, that's fine. When we're looking to treat large areas such as the brain, I prefer scanning, because it's going to cover more of that area. Unless you've got x-ray vision, I definitely don't. So it's the best way of ensuring that we're treating the largest area possible. And then how frequently we then treat, so 2 to 3 sessions in the first week, and then you just wean them down like we do with most laser conditions, and gradually you wean it down to once every 2 to 3 weeks based off clinical improvement. And that's key with any laser therapy that we do. We always base it off clinical improvement. If the patient's doing well, great, keep reducing frequency. If they're not, or you start seeing clinical symptoms start to creep back in, then we know that's where their balance is. So at the moment I have Diesel every 2 weeks, and I will be pushing that out every 3 as we carry on. So that's our canine cognitive dysfunction. What about traumatic brain injuries? So primary area affected is that cerebrum, so again that cerebral cortex. The secondary involvement is that brain stem, the cerebellum, the limbic system, which is that hippocampus. So again, go back to that anatomy. As a result, the patient gets altered consciousness and mentation, seizures, abnormal pupil responses, ataxia, paresis, vision deficits, behavioural and cognitive changes. Underlying changes, we might get contusion, we might get hemorrhage here, and that's an important point that I'll talk about in a moment. Diffuse axonal injury, cerebral edema, and increase in intracranial pressure, ischemia, hypoxia, and neuroinflammation. So there's a lot going on here with traumatic brain injuries. Early intervention assists resolution of clinical signs and also neuroprotective against lingering symptoms, and that was by Oren et al. 2012. Same parameters as cognitive dysfunction. So we're in that same period where we're still exploring parameters. But what we would say here that's different is when our frequency of treating every 12 to 24 hours for aiding resolution of clinical signs. So you kind of treat a little bit more closely together. And this helps to decrease intracranial inflammation, decreases oxidative stress, and stabilize damaged membranes. And then most importantly, subacute trauma should not be treated due to the risk of intracranial hemorrhage. So before you treat, as a vet, before you refer for treatment for traumatic brain injuries, we need to make sure that there is no risk of hemorrhage here, because we know obviously we're increasing vasodilation. The last thing we want to do is, if there is a bleed, is do that. So with all cases that we see, if you're a physio, a hydro, or a vet nurse, or whoever treating, we obviously absolutely have to have vet referral before we can treat any of these conditions. But it's just a really important note, if you're in a clinic situation, so you commonly have access to those patients a lot sooner, we do need to make sure, that subacute trauma period, that we do not have any hemorrhage before we go ahead and treat. In terms of applying, exactly the same as CD, because it's affecting those same areas. So it's held in contact with the dorsal surface of the skull. Treat both left and right hemispheres. If using point-to-point methods, then again we need to hit that irradiance 0.250, 1.5 watt per centimetre square. Skin surface is recommended, and we would again do 2-3 sessions and then wean down as the clinical symptoms improve, and not before. So that's a bit of a longer one, but there's a lot to unpack there. And again, we still haven't hit all the major, the finer details. So I really recommend, if you're treating any of these conditions, go and explore, as vets, having that baseline understanding of when you would and wouldn't treat is really, really important when you're looking to refer on these cases. So that's that one. I'm going to do a mini video, top tips for treating the brain, for part 5, and then we will start moving on to the next area, which I will tell you in the next video where we're going to look at next.